Thank you, Kim. And now I'd like to invite Mary Scroggins to come up.
I'm walking a little crooked today because I have a late effect from chemo 20 years ago, and it is neuropathy. So as you see me waddle, that's proof of principle. Okay. I go off script every now and then. I've been known to do that. Um, and I'm also really nonlinear. So that's my little disclaimer in case I don't cover what you think I'm going to cover. Okay. But I'm going to talk about assessing financial toxicity for patient benefit. And I'm going to probably do this wrong a couple of times. That green arrow? Okay. Okay, and I'm just going to talk from a patient perspective, and I'm not going to tell my story. It's been such an honor to be here today with all of these wonderful advocates as well as all the other speakers, but just a privilege to be here to hear these honest stories and told so well and so thoroughly and with such passion. Um, I often start things with a tribute to survivors and to patients because I think it sort of sets the focus. And sometimes I read it and sometimes I don't. I think I will use a few of my, maybe a minute and a half of my 10 minutes on this. In remission, in recurrence, in active treatment, and in every conceivable state of personal discomfort and challenge, cancer survivors advocate for themselves, their families, their friends, their neighbors, and strangers unable to advocate for themselves. Educate health professionals and the general public about cancer prevention, access to care and treatment, and about the everyday personal side of life with and after cancer. Participate in scientific review panels and clinical trials. Walk, run, and wheel in chairs in support of research funding and legislative action. Put human faces and real lives on the disease. Advocate and fight for equal access, quality care, and the best possible quality of life for everyone. Choose hope, even when despair seems so tempting and requires so little. Understand that every second, every new dawn is a gift, a blessing undisguised. I stand with you, yet I stand in awe of you, and I stand in your debt. I wrote that several years ago for something. But anyway, I wrote it for I think the launch of a magazine that was focused on advocate rights and survivor rights and so on. And I just think it helps me to focus a little bit on what I'm here for. So this really is just my perspective. And I always like to start by being clear that, there is no advocate perspective. Sometimes, it's booked as the advocate's perspective. No, this is how I feel about this. And these are things that I've learned through working with other advocates and chatting with them and working for 20 years with other people whom I think are just wonderful, wonderful health activists. And so I'm going to talk a little bit about why we must and how we can learn more about financial toxicity to benefit patients, families, and the whole system. So clearly, none of us, patients, families, and the community, shouldn't suffer in silence and in pain and in shame, and many of us do. We are ashamed to say what's going on financially in our lives. With all the other things that are going on, that's totally unacceptable. We shouldn't have to choose between medication and care and family health and well-being. This is just very basic. Our quality of life is changed. When you get cancer, everything else just sort of goes out of focus. My family tells it, they say that, the moment that someone came out and said I had cancer, because when I went into the hospital, it wasn't for anything related to cancer. They found the cancer by chance, lucky me, and I do mean that, while I was in there. And I asked one of my sisters about it, and my entire family had come. I have 5 sisters. My entire family had come, and they said when they came out and said that they thought it was cancer, everybody sort of went in a different place. They didn't know how to handle that. And often that happens. Compromise, you shouldn't have to compromise your survival or your survivorship. And I think we need to remember that survival has to do with how long you're here, survivorship has to do with how the quality of your life, and they are not mutually exclusive. And sometimes we behave as if they are. The fear of the result of being exposed, you shouldn't have to fear what happens. People shouldn't wonder that once people know what will happen to my health care and perhaps even my community standing. That's unacceptable. Financial toxicity is inadequately defined and explained. You know, we have sort of shallow coverage of it, but we don't really discuss it. We don't study it enough. It's avoided in part because of embarrassment and discomfort and so on, and that's two-way. Both advocates or patients are a little bit embarrassed, and so are the healthcare professionals who might have to ask these questions. Well, you know, it's uncomfortable, but it's necessary. The truth is, how many of us know our best friend's salary, credit score, you know, those kinds of things we don't know because they're personal. That's why people are embarrassed. If we don't do this well and really study financial toxicity in the manner that's really inclusive and has everybody on the table and being asked the same questions, we can exacerbate health disparities, and nobody wants to do that. It's not fully understood or supported as a legitimate, I think, avenue of inquiry. We study it, but I don't think we study it sufficiently. And the development of interventions will continue to lag unless we do the things that are necessary so that we have greater understanding of this matter. And I think we have an opportunity, but I also think we have an obligation to add to the research and to perhaps add some best practices here. So there are some assumptions that have to do with financial toxicity, which I think get in the way of our really studying it and then more importantly doing something about it. Patients and families are reluctant to discuss financial matters. That's just, you know, whether it's true or not is not the point. I'm simply saying these are assumptions. Health professionals are reluctant and unprepared to discuss financial matters. They are. So what we need to do is educate them out of that, and we need to provide tools and so on, and make sure that people understand how important it is. The reason that patients are reluctant, for instance, to discuss is because they don't know what the outcome is going to be. That once you disclose something, what does that mean? Does it mean that I'm now going to get inferior care? And when someone says, well, I want this information so that I can, you know, adjust your treatment plan so that we might find some alternative care, you know, what that might mean to me, or what I might think it means, is inferior. You used alternative, I'm hearing inferior. Low-income individuals and vulnerable populations are most unlikely to want to discuss these financial matters. We don't know that. You know, that's an assumption. People in general don't like to discuss financial matters. Financial toxicity within vulnerable populations is not health or cancer linked, so we treat it like we think it might be just a pre-existing condition or even their fault. That's a bias. I've heard people say things that mean exactly that. So let's be careful of what we're thinking, because people are very clear when you're talking to someone. Your body language and all kinds of things tell people what you really are feeling, no matter what the question is. Patients, families, and the general public, you know, understand what financial toxicity is or encompasses. No, they don't. We have to be very clear and explain to people what things mean and why we want the information. So you need to say why you want information when you're gathering it and what the potential is that might come from it that would be good. I think we need to establish an assumption-free zone that is also stigma-free, so that everyone that you survey, if you're the person who is conducting a study or who is surveying patients in your office or in your practice, make sure that everybody gets the same questions. And make sure that you explain that they have the option of not answering some questions. But here you're going to have to tread a little lightly, because you don't want to overemphasize the fact that you don't have to answer all the questions, because some of them are going to be difficult to answer anyway. You don't want people to say, okay, I don't want to answer that one. You know, but you want to be clear that they have the option. This is not something that's being forced. You don't want to assume, you do not want to assume who will be open to questions and so on. And you want to allow people to answer as they can. So some people are going to sort of meander because it's difficult for them to answer the question, and they've got to think around it and sort of change it up a little bit and whatever, and try to make it acceptable sometimes to the person who's asking the question. Or conversely, somebody might just tell you everything about their entire life, the first home they ever lived in, you know, everything imaginable, because it's such a difficult conversation. Just listen and take the information down. Another thing is in prejudgment, no matter what the reason, it won't benefit any of us. We get unequal participation and information that cannot be generalized. And so, you know, whether your intent is that you want to be compassionate, considerate, whatever, or if it comes out of bias, we can't prejudge. And we can't make assumptions about general populations and so on, because we will come out with information that is not usable, and again, we will help to add to health disparities and so on. And understand that patients and families may have certain concerns about, you know, providing this information that you're asking for. Again, they may fear that disclosure will not turn out well for them, and that they don't know what they can. So you need to anticipate what they might ask, anticipate anything that might be said, and then sort of turn it around and explain why you're doing this thing. Again, explain why they might want to answer these questions. People are living in shame and they're living in pain over this. And cultural competence people have talked about, so I won't say anything other than to say it's not just about language. I'm so sick of seeing people translate things into Spanish or some other language and think they've done their job and they've been culturally competent now, and I see that little red light. And so I'm not going to go through these. The other things are just some basic considerations that you might want to think about, other than one other slide, in terms of how you might want to make sure that you get the most out of the answers and so on, and you get the most information. So I'm going to go through these quickly. And the last thing here is just, this is an opportunity. It really is, and an obligation. Establish some guidelines on how you're going to do the research. Add to the research base with your own work and studies. Assess needs and so on. Educate and learn from patients. Make sure you do that. Engage patient populations, the advocates, because they are a resource that just you can't get anywhere else. And then help to reduce this and eliminate ultimately all of the suffering and the silence and the shame that surround this, and enhance patient care and outcomes. And these are my little advocates in training. They sent their greetings. Thank you.